Hi, everyone, and welcome to the Center for Optimizing Rural Health's webinar, Future Trends in Healthcare and Their Impact on Rural Hospitals. I am Cassidy Avila, and I will be moderating the webinar today. We are so happy that you could join us. This topic always draws a large crowd, and with the current climate, there is even more interest in what the future of rural hospitals look like. And there is no better person to speak on this subject than Mr. Jamie Orlikoff. But before I introduce Mr. Orlikoff, I would like to let you know that we will be recording this webinar and posting it to the CORE website. And we will also leave a few minutes at the end of the presentation for questions. So feel free to send a message in the chat box to everyone or anonymously to me, Cassidy Avila, and I will ask the question on your behalf. So with that being said, I am honored to introduce our speaker. Mr. Jamie Orlikoff is president of Orlikoff & Associates, a consulting firm specializing in healthcare governance and leadership, strategy, quality, patient safety, and organizational development. He is the national advisor on governance and leadership to the American Hospital Association and Health Forum. He was named one of the most 100 powerful people in healthcare in the inaugural list by Modern Healthcare magazine. Mr. Orlikoff has been involved in leadership, quality, and strategy issues for over 40 years. He has consulted with hospitals and systems in 12 countries, and since 1985 has worked with hospital and system governing boards to strengthen their overall effectiveness and their oversight of strategy and quality. He has worked extensively on improving the relationships between boards, medical staffs, and management. He has written 15 books and over 100 articles and has served on hospital, college, and civic boards. He is currently a member of the St. Charles Health System Board in Bend, Oregon, and was the vice chair of the Virginia Mason Health System Board in Seattle, Washington, and chair of their governance committee. So, Mr. Orlikoff, I thank you so much for being here, and I will turn it over to you.
Thank you, Cassidy, and welcome everyone. And let me start by thanking you all. It's very challenging running rural hospitals in a normal environment, and doubly challenging in the COVID-19 pandemic environment. And what I'm going to try to do are, divide my comments into two categories: pre-COVID and then, post-COVID. What are the implications of COVID on the trends which have been impacting rural hospitals? How are they being accelerated or minimized? And then how can we try to respond to those? So let's jump in. I would just say that pre-COVID, there were four major kind of themes which existed, and those were basically a focus on total cost of care. We had reached the point in American society where no one could afford the cost of health care. Individuals couldn't do it, families couldn't afford it, businesses couldn't afford it, state governments could not afford it, and federal governments could not afford it. And even healthcare providers could not afford the cost of healthcare for their employees. So the cost of care issue is a major, major theme, and we'll talk about that a little bit more. The rise of consumerism and the need to engage consumers, which is challenging for everybody, but especially challenging for rural facilities who both may not have the resources to do this and tend to have a different perspective and relationship with their communities. The never-ending focus on quality and safety and the emergence of both of these as dominant strategic competitive imperatives. And this is a major issue for rural hospitals is, does your community believe that the care that you provide is safe and that it's of high quality? Because if they don't and they have insurance, they can bypass you. They can go to other providers, which is one of the main sources of risk that rural hospitals are being exposed to. And then the fourth theme is the challenge of effective governance and effective leadership of rural hospitals. And let me kind of just stop there for a second and just reiterate the thanks, especially to those of you who are board members. Your communities have never needed you more than they need you now as you attempt to reconcile the trends which are very negative for rural facilities with the complications of the COVID-19 pandemic. So let's explore some of them in some detail. So here, going back to an earlier, simpler time, about a year ago, a little over a year ago, you can see that theme of cost of care. And this was a quote from Jerome Powell, who is the chair of the Federal Reserve Board, testifying to the Senate Banking Committee, who basically said the U.S. federal government is on an unsustainable fiscal path The debt as a percentage of gross domestic product is growing and now growing sharply. And then I emphasize this comment that he made. The single biggest thing that drives the unsustainability is healthcare. He referenced 17% of gross domestic product. We're now at 18% of gross domestic product, and every other country spends 10%. And then he points out, it's not that the benefits are too generous. We just deliver them in inefficient ways. And we've certainly seen examples of that in the COVID pandemic. But let me just emphasize, one of the long-term implications for all of healthcare, but especially for rural facilities, is, as you know, the attempts to bail out the country from COVID have just immeasurably added to the debt of the United States and increased the percentage of debt relative to GDP to the extent that we're in a much deeper hole, much deeper hole now than we were when Chairman Powell made these comments, which will then just exacerbate the pressure on federal programs like Medicare and federal supported programs like Medicaid. So we can expect either big change in the system, or if the system remains as is currently configured, aggressive downward pressure on reimbursement to hospitals and physicians from Medicare and Medicaid. So the exacerbation of the payer mix challenge will simply get worse because of this. And another interesting article I saw, Dr. Marty Makary out of Johns Hopkins, who wrote a wonderful book if you're trying to deconstruct the great challenges of figuring out how we price our services and costs and things like that, wrote a wonderful book titled The Price We Pay. But his team at Hopkins kind of did some really in-depth analysis, and they estimated that 48% of all federal spending goes to healthcare. So of every tax dollar you give to the federal government, 48 cents goes to healthcare. And then they broke it down and said, well, 27% goes to Medicare, 11% goes to that portion of the budget on Social Security that then funds medical expenses. 4% goes to healthcare spending on veterans. The military healthcare system consumes more than 1% of all federal tax dollars, and so on. So you can see, that anywhere you look in the American financing system, you see healthcare in the background. And what do we get for all that money? And I'm not going to bore you with this because you've heard this before. I'm just going to show you one or two visuals. The problem is all of the data shows that we don't get nearly a commensurate benefit for the amount of money that we're spending compared to other countries who spend far less of their economy on healthcare and have much better health statistics. And so there's one visual that I'm showing you shows that, up until in 1915, 1916, and 1917, excuse me, I'm showing my age. In 2015, 2016, and 2017, life expectancy declined in this country. So that was 3 straight years of decline in life expectancy. And this is before COVID. And it's important to understand that the last time there was a 2-year drop in life expectancy was in the early 1960s. But the last time in this country's history that there was a 3-year drop, 3 consecutive years of decline in life expectancy, was back in 1916, 1917, and 1918, a period which included, World War I and all the mortality generated from that, but also included the Spanish flu pandemic. And so we were very worried because we said, we don't have a pandemic going on in 2016, 2017. Why is life expectancy going down? We're spending all this money on healthcare and life expectancy is declining. And then we were very happy when it stabilized at the end of 2017. And now we're pretty confident because of COVID, life expectancy is going to decrease again. And whether it'll just be a short-term blip or whether it'll be a multi-year trend is yet to be seen. But the issue is, our healthcare costs keep going up, growing faster than the rate of economic expansion, growing faster than the rate of inflation, and growing faster than the rate of wage growth. And we've all known that, for years that this couldn't continue, and we're hitting the point where it is destabilizing the economy, and COVID is simply going to accelerate this. And much of the growth is being driven by accelerations in Medicare spending, with the aging of the baby boom into the Medicare program, and by growth in private health insurance spending. But when you ask, what's one of the reasons the costs go up, it's really not because of excess utilization. It's really got to do with our pricing structure. And this visual shows you, quoting the late, great economist Uwe Reinhardt, it's the price is stupid. The bottom line on this graph, the yellow line, is kind of a measure of utilization, use of medical services, and that actually decreased by 0.2% from 2013 to 2017. But prices rose 17% over that same time period. Healthcare prices are not connected to utilization. So we saw utilization going down and prices kept going up. So we're going to have to figure out a way of analyzing our cost structure and how we translate that into prices if we can figure out some way of stopping this trend. But the impact on Americans is undeniable, and you can see it in this graph, and this is the last complicated econometric visual I'll show you. But what this graph shows you is it goes from 1999 to 2017, and it's focused on the United States. And that first line, that black line at the bottom, shows you the rate of overall inflation during that time period, so about 47%. So what cost me $1 to purchase in 1999 cost me $1.47 to purchase in 2017. The next visual right above that, the next line, the blue graph, is the rate of increase in worker earnings. So how much has my income increased? And that increased 64%. So what you can see is if that's all we're looking at, you've got a good encapsulation of the American dream. My wages as a worker are growing faster than inflation, which means I can put some money away, or I can maybe buy a house or put a kid through college or take a vacation or fund my retirement, which is kind of the essence of the American dream. So everything's great. What's the problem? Well, the problem is when you look at the top of this graph, you see the implications of healthcare on that American dream. And so that next line, the third line up, kind of the orange line, shows you the rate of growth in the cost of health insurance premiums for families. And that grew 224% during that same time period. But the line I really want you to pay attention to is the top line of this graph, the yellow line, which shows you the rate of increase in contributions that workers had to make to their own health care costs in the form of premium shares, copays, and deductibles. That increased by 270%. Now, the scale is different, for these, but the question is the difference of the rate of growth in my wages over inflation, does that include the growth in my worker contributions? In other words, am I still earning more than the rate of inflation? Are my wages growing faster than the rate of inflation when you factor in the cost of my contribution to healthcare? And the answer is an unequivocal and resounding no. So because of my contribution, because of the cost to healthcare, my standard of living has declined. My wages are not growing faster than the rate of inflation. And as a result, the American dream is receding. And this is one of the core reasons we're seeing the hollowing out of the middle class. We're seeing deaths of despair, in populations we hadn't seen it before in certain demographics. And healthcare is at the center of this. And so one of the things that we're seeing is the market attempting to address this issue, not in a rational or reasonable way, but by closing down healthcare providers. So we're seeing hospitals close. We're seeing, variable income pressure on different types of providers. Now, again, pre-COVID, one of the things that we saw was Medicare was increasing some of the funding and delaying some of the expected cuts for hospitals in general, but specifically for rural hospitals. And as a result of this, we thought that operating cash flow was going to grow somewhere between 2 and 3% in 2020 because of the highest Medicare reimbursement rate increases in the last 10 years. And as a result of this, Moody's said, well, okay, we had a very negative outlook for not-for-profit hospitals, and we'll change that to stable. So 2020, if not looking like a great year, was at least going to be a fairly stable year before COVID. But even then, even with that, what we saw was independent hospitals were disappearing. And this is a graph taken from a Modern Healthcare piece in late 2019. All signs point to independent hospitals going away. And you can see standalone hospitals in terms of the number of acute care beds declining, system-affiliated hospitals declining, patient days, standalone hospitals declining, slight increase for system-affiliated hospitals, And in terms of net patient revenues, you can see the same thing with system-affiliated hospitals doing just a little bit better. So hence the movement towards systems. But even the point of those last two visuals was even with healthcare reimbursement stabilizing and the prediction being that 2020 was going to be a reasonable year, we were still seeing just incredible pressure, incredible downward pressure on hospitals in general, and in particular on rural hospitals. And what we saw was, and let me update this for you because just to show you how quickly things are changing, this visual was current as of February of this year. And at that time, there were 119 rural hospitals that had closed since 2010. There are now, in just 2.5 additional months, 130 that have closed. So 11 hospitals rural hospitals have closed in this country since the end of February and toward the end of May. So we've lost 130 rural hospitals since 2010. And we've lost 172 rural hospitals in this country since the year 2005. So we're seeing, and you can see this map to the left of the visual. You can see the distribution of where the rural hospitals that closed, and then the type of rural hospitals that closed. And what you're seeing is that they tend to be in the southeast, but more importantly, they tend to be located in rural areas which are relatively contiguous to metropolitan areas, which then speaks to the issue of bypass of people in your community going elsewhere to get their hospital care as opposed to going to your rural hospital. So very, very worrisome trend, and this was before COVID. And so again, before COVID, and this was February 20th, when we had a hint that it was coming, but we didn't really understand the implications of it, groups analyzing this said about 21% of rural hospitals are at very high risk because of their finances of closing their doors because of degradation in the payer mix, significant declines in inpatient utilization, limited capital, much higher risk. And so that represented about 21,000 staff beds, 707,000 annual discharges, and about 21 billion in total patient revenue if those 21% of rural hospitals actually closed. And by the same token, about 1 in 5 Americans, or about 60 million people, live in rural areas and depend on their local rural hospitals for health care. And so you see the data there, just kind of reporting how many have closed. And the reasons, what were the reasons? Because we have to think about this, both to think about strategies you can develop to combat these, and then also to think about how has COVID exacerbated or minimized any of these reasons. So some of them, A, significant degradation in payer mix, growth in indigent care, growth in Medicaid, growth in Medicare, and corresponding decline in privately insured patients or patients with money in their pockets. And one of the reasons for this is this kind of tautological issue, because healthcare costs are so high, we can't really keep manufacturing jobs in this country. So we're losing manufacturing jobs, we're losing agricultural jobs, which then kind of feeds on itself and increases the rates of uninsured and the rates of people enrolled in Medicaid. Secondly was the massive declines in inpatient care, which drive excess capacity. Many of you before COVID, if you were a critical access hospital and you were licensed for 25 beds, it was not uncommon at all to find hospitals with an average daily census of 6, 7, 8, or 9 patients. And so you had this really kind of disconnect where you had a capacity which, as we'll show with COVID, may not be sufficient to serve your community in a time of acute need, but during normal times, you had excess capacity, and that was driving excess cost. The difficulty to leverage innovation, much of this breakthrough innovation that we're talking about, really takes a great degree of resources. It's not just, you got to think about how to be innovative. You've got to have the time, you've got to have the resources to try to translate that innovation into applications which can then return. And the economic pressure made that very untenable for hospitals. And in addition, we're seeing newer challenges as a result of the growth of technology and the change in the payment system, the shift from inpatient to outpatient care. And around the country, we're seeing things like, hospice at home and critical care at home and hospitalization at home, and things which used to require 4 or 5, 6 day length of stays can now be done on an outpatient basis. an increased regulatory burden, and a growth in the cost of pharmaceutical drugs, which then gets pushed to hospitals and physicians as the risk gets transferred. In addition, some of the newer challenges, one of which I mentioned, which is referred to as bypass. And bypass behavior is when your residents, residents of your community don't seek care at their closest hospital, but instead they look to go to a bigger hospital that may be as far as a 4-hour drive away. And if it's less than that, it makes it even that much easier for your residents to seek care elsewhere. So this creates a kind of a loss of revenue, especially because it tends to be the privately insured patients who avail themselves of the opportunity to bypass your local hospital, and that creates greater financial distress. The growth of technology in healthcare, and specifically telehealth, which we'll talk about as one of the major kind of long-term implications of the COVID pandemic, but that issue that many people can now get services which don't require a hospital stay, which then reduces the revenue for the hospital, especially rural ones, which may not have the resources to access this new technology to try to recapture that potential lost revenue. And not meaning to cast aspersions, and I'll give you a couple of examples of this in a few minutes, mismanagement or weak governance. That we've had some cases of fraud, we've had some cases of regulatory malfeasance, failure of boards to effectively oversee. So those are some pretty significant challenges. Now, what are some of the solutions to it? And Bruce Siegel, who's the CEO of America's Essential Hospitals, basically said, well, ensuring rural access demands that we embrace collaboration and technology. Telehealth and partnerships between rural hospitals and tertiary centers will be key to ensuring the right care is delivered at the right time. And I think Dr. Siegel is right, and I think that's exactly correct. The problem is that the current reimbursement system can actually penalize rural hospitals for doing exactly that. So to make that point, the first thing we have to understand is that in rural areas, high deductible plans are even more prevalent than in urban areas, and incomes tend to be lower. So if you have insured populations, which normally are the desirable aspect of the payer mix, if you can capture patients who have insurance, you're going to get more reimbursement than if you capture patients who have Medicaid, who are indigent, or even Medicare. But the problem is in the rural environment, higher deductible plans are more prevalent. B, incomes are lower, so there's more challenge for rural residents to afford their deductible. And now let's add to this. When you establish those collaborative relationships that Dr. Siegel was talking about, there's a very unique kind of hidden trick of reimbursement which hurts rural hospitals. And that is frequently a patient will come to you and you will stabilize that patient, recognize that that patient needs to be transferred to a larger regional or urban hospital with which you have some type of collaborative relationship, and then you transfer that patient. And that's great. You've done exactly what you're supposed to do. The problem comes when you submit your claim from the first site of care, because typically what happens is the first site of care is applied to the patient's deductible. And if the patient cannot afford the deductible, those hospitals, i.e. your hospitals, rural hospitals that were the first site of care, frequently don't get paid, even as the larger tertiary hospital or urban hospital where you transferred the patient to, they tend to get close to full payment from the health plan. So this is one of those reimbursement kind of nuances, deeply hidden nuance, which takes that notion of collaboration and turns it on its head. Because you can collaborate and you can do so in the best interest of your community, in the best interest of your patients, but you can bear a direct negative financial consequence of that. And the hospitals that you're transferring the patients to bear no consequence from that. They almost get full reimbursement. So this has significantly increased bad debt for rural facilities. And this is one of the hidden reasons why many rural hospitals are teetering financially. So here comes a strategy, which is it's very worthwhile. You're looking at that particular issue in your community and in the relationship or relationships that you have with tertiary or urban hospitals that you transfer patients to, and see if you can figure out some way of negotiating with them so that they bear the burden of the deductible not being paid, or at least they share it with you as well as share the reimbursement that they're getting. Otherwise, this flies directly in the face of that concept of collaboration and trying to figure out a way of benefiting from the transfer of patients from your facility to other facilities who may be better equipped to care for their severity of illness. So, big issue and hidden issue, you know, very few people are familiar with that. But actually trying to do the right thing ends up penalizing rural hospitals for the reasons that I talked about. And why is it so important that you continue to exist? And so let's talk about, you know, that kind of urban-rural dynamic. And I already showed you how many people live in your communities, you know, 20% of the American population. But what's the impact when a rural hospital closes? And when a rural hospital closes, the mortality rate in the region that it serves increases by almost 6%, by 5.9% to be specific. This isn't the hospital mortality rate. This is the overall mortality rate in the community. So this is why you are so critical to your communities. And by comparison, when an urban hospital closes, there is a negligible impact on mortality in the urban area. So stating the obvious, with data, you are so much more critical to your communities than say, any individual urban hospital is to its community, that we've got to figure out ways of you know, keeping you in business. And one of them is going to the urban hospitals or the tertiary centers that you refer to, and making the point about that reimbursement model not being fair, but also having a disproportionate impact on people's lives and on mortality. So is your hospital at risk of closing? And I'm going to give you a couple of COVID indicators here too, because this is kind of the end of the pre-COVID world, and now we're going to talk about what the implications of COVID are. But first, before COVID, you know, the most at-risk hospitals tend to be in southern states where, and even if you're not in a southern state, you know, these points are very important. Is your inpatient volume shrinking? Are your margins declining? Are urban competitors encroaching, even if they come to you as collaborators? In working out transfer agreements, are you starting to see more bypass behavior? You know, people who have private insurance in your communities leaving your communities to get health care elsewhere, and then that kind of transfer risk where you have to bear the burden of patients who don't pay their deductibles, but the hospitals that you transfer your sick patients to, you know, don't bear that burden and get the benefit of being the secondary hospital, not the primary site of care. And unfortunately, we're seeing, you know, a kind of a disproportionate spread of income across rural areas. But if your resident populations are poorer and sicker, if you're seeing a decline in the jobs base, and if your governance and leadership is, you know, hasn't changed much, those are pretty strong indications that, you know, you're on the road to significant challenge, if not closure. So one of the first things we have to do is be very clear-eyed in the assessment of where we are and embrace the concept that hope is not a strategy, that just because you are essential, you are critical to your community, that doesn't mean someone's going to ride in and save you. And my big worry is it's even less likely now because of the, you know, almost incalculable increase in the debt because of the government's response to the COVID crisis. Now let's talk about COVID right now. What increases your risk of closing if you're a rural hospital in terms of COVID? And the answer is, well, what's your risk of getting overwhelmed by COVID patients? What's your risk of having a surge which, you know, overwhelms you? And there are kind of three predictive risks which you want to be thinking about. Number one, do you have a meat packing plant or a food processing plant in your community? Number two, do you have a prison in your community? Because those two areas, meat packing and food processing plants, chicken processing plants, and prisons are the primary hotspot kind of incubators of the virus, which can then shed them into their communities. And what's the third one? You know, the third one is, are you a destination location? Do people come to your community seasonally to vacation, to hike, to ski? Are you a college town where you have an influx of people coming from many, many, many different locations all at once who might bring the virus to your community. So those are the, you add that onto these, and those are the 3 COVID risks. Do we have a food processing plant? Do we have a prison? And are we a location, a destination location where people come to go to college, where people come to, to work, or do we have a vacation location here? So those are some of the things which contribute to that. Now let's just key in, going back for a second, to this governance and leadership being weak issue. I don't mean to offend you, but I need to tell you that you really got to step up your game. Everyone has to step up their game. And to give you an example, Georgia, the state of Georgia, which was experiencing a rash of closures of rural hospitals, became alarmed when they discovered that many executives and board members of their local rural hospitals did not have skills in understanding financial statements or understanding how to do strategic planning. And they offered education and training, and the boards and some of the executives said, we don't have time to do that. I'm busy in my real life. And we get it. We understand what's going on. And basically blew off Georgia, blew off the state of Georgia. And what this motivated Georgia to do was to pass a law requiring that board members of rural Georgia hospitals and their CEOs and chief financial officers must complete at least 8 hours of continuing education on these topics, or risk being fined and losing valuable state tax credits. And this was simply because they weren't availing themselves of proffered educational opportunities like this webinar. And said they didn't have the time to do it. And the state officials were watching in horror as one of the reasons contributing to hospital closure was weak governance and ineffective management that wasn't responding to a predictable downturn of events until it became too late. So make certain that your organization is not like this. Are all of your board members educated? Do you require continuing governance education? You got to lift your head up and figure out what's going on in order to, make the benefit of when your head is down doing the work to start to pay off. So that's just an example of some of that kind of weak governance and weak management, why I gave you that example. And incidentally, going back to that for a second, you may be interested to note, if you look at the citation on the bottom of this visual, I'm not quoting a Georgia newspaper. I'm quoting the Seattle Times in Seattle, Washington. Now, why would that story appear in a Seattle newspaper? It's because the Washington press was lamenting the loss of rural hospitals in the state of Washington. And they were saying, look what Georgia did. Maybe we need to do the same thing in Washington state. So please don't think this is just a Georgia issue. This is all around the country. So again, some pre-COVID questions you'd have to ask yourself. Can we survive while staying independent? And why do I emphasize that? Because having done a lot of work with your cousins and your colleagues with rural hospitals around the country, and being the chair of a board of a health system which has rural hospitals in it, I know how important the concept of independence is in many rural communities. It's our hospital. We want to keep it. We don't want to join a bigger system. So you've got to be able to link and delink the concept of survival with independence. Can you survive and remain independent? And if the answer is no, what will you do? All right. And the more important question is, can you thrive while staying independent? And what's the difference here, and how does this kind of segue into the COVID portion of the presentation? And that is, many people answered yes to question number 1, but now because of the COVID crisis, realize the answer to question number 2 is no. And so if there is any doubt, there is no doubt. Meaning if you are nagged by that question or really don't think that you can do both to either question 1 or 2, then the issue becomes, is an integration with a larger system in your future. And if you're thinking affiliation, you're thinking of merger with a system, it's extremely important to initiate that from a position of relative strength. I've seen a lot of rural facilities who said, where their leaders said, we're just going to fight the good fight. We know we can't survive indefinitely. We know sooner or later we'll have to join a bigger system. And when that time comes, then we'll join the system. And what they find now is you may have some people who are interested in folding you into their system now, but if you wait until your back is against the wall and you're a decayed asset, that they may have made other arrangements and they don't need you so much. And I've had that happen. I had a client in southwestern Michigan, a rural facility, that 4 years ago thought about joining a system, and they put out, a request for proposal, and they had 5 systems respond saying, yeah, we'd be interested in talking about folding you into our system. And they said, after they looked at it, they said, well, we'd like to go it alone for a while longer. We want to remain independent as long as we can. And they did so for about another 4 years. And then when they only had, less than 20 days cash on hand, when their back was against the wall, then they said, okay, now let's merge. And they put out another RFP, and this time they only got 1 response. The other 4 systems that responded previously said, we've made other arrangements. We don't need you anymore. Only 1 system responded. So I tell you that because, those of us counting on a white horse riding in to save us at the last second, things have changed, and many of the economic challenges have fit, that have impacted rural facilities are also impacting big healthcare systems. And so you can't count on them being there. So if you think you need to do this, do it from a position of relative strength. All right, so those were the general trends. What does COVID do to these trends? Well, first of all, it accelerates them. It makes them more random. Some of you have not experienced a surge in COVID patients. Others have. Some of you will experience a surge. Others may not. So it's going to make it very individualistic and almost Darwinian, where we're going to start seeing different situations play out for different rural facilities depending upon how their communities are experiencing COVID. And so the way I summarize this is, you are caught in the middle of this incredible system tension for the whole healthcare system of, do we have a just-in-time healthcare system, or do we have a just-in-case healthcare system? And those of you who are followers of lean know that just-in-time is this principle where we don't want excess inventory, we don't want waste in the system, we want the system to be taut and efficient. And that's great. The problem is when the system is taut and efficient in normal times, it means there is no just in case when you have a crisis or an emergency like we did with COVID-19. And this is one of the reasons that people are saying, how can the richest country on the face of the earth have a shortage of items so mundane as N95 masks or cotton swabs, or basic medications? I'm not talking about ventilators. I'm talking about basic medications that you need to take care of a ventilated patient, like an analgesic or a paralytic or an anesthetic. And that's because just in time means there is no just in case. When you have a just in time supply chain that's designed to capture maximum efficiency in normal times, when the pandemic came, we saw its immediate limitations. Just in time meant there was no just in case. And it also meant that suddenly now, as opposed to being a hospital system or a collection of rural hospitals working together, we had to compete with each other, driving up prices. So hospitals actually had to compete with each other in the market to try to get equipment, supplies, personal protective equipment, medications, things like that, which perversely drove the price of these items up just when we needed them the most, and then made them, far less available. So this then put rural facilities at greater risk because they didn't have the financial wherewithal to be the top bidder, and so on. So think about us relative to the supply chain weaknesses, and I just talked about one, but there are 4. The just-in-time focus. Number 2, the incredible complexity of the supply chain, which has just been exposed, which meant if there was a break in one piece of the supply chain, it reverberated throughout the whole supply chain and made the end users, your rural facility, much more likely to have shortages of critical stuff that you needed. Third is this issue of offshore manufacturing combined with number 4, single or limited suppliers. And man, we should have learned this lesson, because you remember about 3 or 4 years ago, there was an earthquake in Puerto Rico. And, and so what? Well, so what was, there's one factory that produces all of the IV bags that we keep saline solution and other fairly mundane things. And suddenly they were the only one who made it, and they were destroyed. And there was an immediate reverberation throughout the whole supply chain, and we had to stop doing surgeries, and there were certain patients we couldn't take care of because we didn't have saline bags to hang in IVs. We didn't have lactate and ringers and things like that to hang in IV bags, and we learned nothing from that lesson. And then that same thing happened to us with COVID, and this got the attention of President Trump. And just about a week ago, on May 15th, he was doing an interview, and this was his quote. He said, "These stupid supply chains that are all over the world. We have a supply chain where they're made in all different parts of the world, and one little piece of the world goes bad and the whole thing is messed up. We should have them all in the United States." Great. Well, that's wonderful. The problem is that, you know, our healthcare cost is so high, it's very difficult for us to manufacture things in the United States without their cost being so high. So what this really means is we're going to have to reconcile this just in time versus just in case. And if we want more just in case capability, you know, we've got to figure out a way of paying for it. So you can make the supply chain less tenuous, less complex. You can make more things in the United States, but then the cost during, you know, normal times of operation will likely go higher. Now, the problem is we saw this incredible confluence come together. And this quote really points it out. This is a public health director for emergency preparedness in Minneapolis, you know, who just at the beginning of the COVID crisis, before it really started taking off in early March, said, people don't understand how close the American healthcare system runs to capacity every single day. We don't have the trained staff much beyond what we have now. Patients wait in the emergency department in many cities on a routine basis. And if you talk about adding a pandemic onto that, there are going to be compromises. And that's a really important point, is we have to think about our capacity, not just in terms of stuff, but what's especially important for rural hospitals is staff. All right, is do you have the capacity to staff up to deal with a surge? And that's what this comment was about. Next, we got this incredibly contradictory message from the federal government. This was a quote from the Surgeon General on February 29th of 2020. Stop buying masks. Seriously, people, stop buying masks. And now the CDC advises Americans to buy masks and wear masks. So we keep getting contradictory information, which encourages people to operate in their own best interests, which then generates further supply of equipment when it's needed for a surge. And something for those of you who have not experienced surge, who've not had a great run of COVID patients, and still may, is learn from your cousin and colleague boards where it has happened. And that is, we grossly overestimated our supply of PPE inventory. And the burn rates were about 4-to-1 to as high as 8-to-1. What does that mean? Before a hospital got hit with a wave of COVID patients, if they estimated they had 4 weeks of personal protective equipment, when they got hit with COVID, they burned through that in 1 week. And sometimes it was bad, as they said, we have 8 weeks of inventory, and they burned through that in 1 week. So this whole issue of, one of your challenges is going to be is, if you're not experiencing surge, how can you build up your inventory, which costs money, so that you're prepared to use that inventory judiciously when you experience surge? Now, one of the other great challenges that we're all facing was the incredible reduction in revenue, you know, because 55% fewer Americans sought hospital care in March and April than they did previously, year over year, because they were scared. People, you know, said, if I go to the hospital, I'm going to be exposed to COVID. So hospitals around the country, for that reason, but also because they were required to suspend elective procedures to prepare for COVID, we saw, you know, 45 to as much as 65% declines in our revenue. While if we were lucky, our expenses remained flat, and if not lucky, our expenses increased as much as 10%. So hospitals were losing conservatively about $60 billion a month. And so now we're very concerned about a rush to revenue. As we start to open back up again, everyone's really interested in trying to maximize, you know, the provision of elective procedures to recapture revenue. And you can see where we took these losses in service lines, and you can also see the impact to the top 10 inpatient procedures, a 99% reduction in knee replacements, an 81% reduction in spinal fusions, a 79% reduction in primary hip replacements, and everyone's chomping at the bit to get that revenue back. You've got to consider, however, that it may not come back, you know, because everyone is saying, oh, how are we going to deal with a rush to revenue? And I want to talk to you about that for a second, because it may not come back, or it may come back only sporadically. And so here's the worry. Millions of patients who put off care or had it delayed during the pandemic can soon be expected to flood hospitals seeking care. And then here's what I highlighted, because I want to challenge this. Many facilities will likely be hard-pressed to handle the resulting surge in patients. So I'm seeing a lot of hospitals saying we have to gear up, forget PPE for COVID. We have to gear up to deal with this surge in wanted elective procedures, which are going to come back to the hospital. And then the quote goes on to say, and this is going to be a challenge while you're maintaining capacity for COVID-19 patients, which I agree with. But I want to push back on the notion that you're going to get that release of pent-up demand. First of all, we know that Americans are much more likely to delay or forgo medical care due to cost. So let's bear that in mind as we think about this. And as I give you 4 or 5 reasons why that surge in elective, highly reimbursed procedures may not happen, especially for rural facilities. Number one is patients may still be afraid to go to the hospital if they think that they might get infected with the coronavirus there. Further, they may be further dissuaded from going to the hospital when they learn that hospitals have policies limiting the number of visitors that they can have. And you can see that, how has the crisis changed the way that hospitals operate? 95% of hospitals said, we've limited visitors, and many hospitals don't allow any visitors. So both of these can be very off-putting. Skyrocketing unemployment. So people who, I may have, before COVID hit, had a job in your community and planned to come and get my knee replaced in your facility, and now I still need my knee replaced, but I no longer have my job and I've lost my health insurance. Or I no longer have a job and I may still have health insurance, but I can no longer afford that copay or the deductible, which was affordable back when I had a job. So unemployment can impact this, and you can see the data. In 2018, before COVID, 27 million Americans did not have health insurance for any part of that year. All right. And during the COVID crisis, about 27 million Americans have lost their employer-based health insurance coverage during the pandemic. And this, unfortunately, tends to be disproportionately larger in rural communities. And just just a study of Americans at large, 45% of Americans personally, either themselves or had someone in their household lose a job, and of that, 26% lost their health insurance. So here's another reason why the pent-up demand may not happen, or if it happens, it will be a very negative payer mix. You may get a lot of pent-up demand in the Medicaid population, in the indigent population, and maybe even the Medicare population, but perhaps not in the private pay population. Another reason is because the COVID pandemic has accelerated some of the transformative aspects of healthcare, specifically telehealth. This crisis has normalized, accelerated the normalization of telehealth, and regulators have changed their views on it, and payers have changed their views, and telehealth has exploded. And that's great if you can capture revenue from it. But if you can't, here's the problem, is that while I cannot get a knee replacement through telehealth, I can access a second or third opinion, and one of those people might tell me, hey, there's another way of treating your knee pain other than surgery. And so telehealth could also reduce demand. And you can see that, we're starting to see those individuals who can't, or those facilities, access telemedicine, telehealth. It spurs patients to move away, which may accelerate the bypass strategy. So that's part of that trap that rural facilities can be in. If you can't access the use of telehealth services to capture patients, it may be perversely driving, the loss of your patients due to bypass behavior. And then last, now the other thing that we're seeing is concern among your staff. And we've seen this in several hospitals that are gearing up, which is if your staff who were laid off or furloughed, they're not frontline COVID staff, but they're nurses, anesthetists, surgical nurses, surgeons, floor nurses, they may be concerned that they may be exposed when they return to work. They may be exposed to coronavirus. And now this gets us back to the inventory issue. If you don't have enough PPE inventory, so that if I'm a surgical nurse and I say it used to be when I came to work and I was in the OR, I just used a surgical mask, but I'm not comfortable doing that. I want an N95 mask. And if you say, well, we don't have enough to give you, and you can't bring your own in from home, you may find that you don't have enough staff to meet demand should it emerge. So that's that whole issue of you want to think about not just supply in terms of stuff, but also staff. And here's just a quick lesson from history. If you go back, say, to the Battle of Britain, right after the Brits' horrific loss at Dunkirk in World War II, the problem the Brits has was not that they didn't have enough planes. They had plenty of, Spitfires and Hurricanes, plenty of them. They didn't have enough pilots. And they were actually sending pilots into combat who only had 6 hours of flight time, in aircraft. That's how desperate they were to put pilots into machines. So one of the great challenges in rural facilities is you've got to take care of your staff. You've got to really key into how the staff are feeling. Do they feel like they're being taken care of? Do they feel like they're being protected? Because if they don't, they may not want to come back to work, or if they do come back to work, they may not, you may have big safety issues that you otherwise wouldn't, as they hesitate to care for patients in ways that they normally would have, or hesitate to respond to emergencies. And this is the lesson we learned from SARS as well. In Toronto during the SARS outbreak, 44% of the total cases were among healthcare workers. And this is the worry. Look at this quote, and especially for rural environments. If this takes place in the United States and we see those numbers of workers being sent home or in the ICU being taken care of by their colleagues, things will start to unravel. And this is especially true in rural environments. If I'm a healthcare provider and we have a couple of patients in critical care that I know because they're my colleagues, you can get a very negative self-fulfilling feedback loop. And you can see this next visual, which you can read at your leisure. We're seeing that happen around the country where staff are complaining, our organizations aren't taking care of us. They're making us do things which are unsafe. Here you see a nurse saying we felt like we were being sheep sent to slaughter. And, as of May 7th, there were over 10,000 healthcare workers, hospital workers who tested positive for COVID-19. At least 79 nurses have died from COVID-19. So how can you take care of your staff to make sure you can deal with this release? And then lastly, and here's my big concern, if we open up the economy too quickly, we could see a resurgence of COVID, and then we'd have to suspend elective work again, and we could get locked into a vicious cycle, which could then whipsaw the healthcare system in general and would be particularly devastating to rural hospitals in particular. So, one of my pieces of advice as a result of this is don't assume that you're past the crisis. We can see a rolling crisis which affects different communities at different times. And in this Darwinian model of you're on your own, you can't expect people to ride into your rescue. So what might the future hold? In addition to what I just told you, if you really want to get worried, think about the supply chain issue again. The issue may not be developing a vaccine for coronavirus. The issue might be distributing it because the supply chain is so weak, glass vials, stoppers, and plus we have multiple pharmaceutical companies being encouraged to compete to see who can come up with a vaccine first. And it's possible we'll have 2 or 3 vaccines made by different companies, some of which will need certain types of vials, glass vials. Others can use plastic. Some can use rubber stoppers. Others can't. So please be prepared for a massive, massive kind of gunk up of the supply chain again for the distribution of vaccines. So if you want to look ahead, it's how are we going to access and distribute vaccines in our communities? So I think that's something we're going to have to think about. We're going to have to think about the very interesting issue that healthcare, as I said at the beginning of this presentation, only represents 18% of the American economy. But when we had to suspend elective procedures and lay off workers and furlough them, it contributed to a 50% decline in the gross domestic product. So the impact of healthcare on our economy is disproportionate to the consumption of resources. Your hospitals in your rural communities are the largest employer for most of you in your community. They're a major driver of economic value to the community, and making this clear to the members of the community so that they can be more willing to support you is absolutely crucial, because this was the biggest factor in the 4.8% decline in first quarter GDP. Next, and this is the worrisome thing, is if we actually do see a resurgence in COVID, look at how much it will cost. And this was from a recent article in Health Affairs that showed that if 20% of the population becomes infected, it would cost the hospital industry $214 billion, $4 billion if 50%, and over $650 billion if 80%. And that would just knock us out of business, especially the rural providers. So we're on a knife's edge right now. And depending how it plays out in the next several months, it could get a lot worse for the system, but also there can be individual pockets of crisis. And that's what you as rural providers really need to be thinking about. Do we have enough PPE inventory? Are we at greater risk of having a COVID resurgence or a first-time surge if you didn't have one? Don't just think you're out of the woods. Are you prepared to deal with it? Are you on top of the issue of trying to capture elective procedures and cognizant of when you may have to suspend them again? And are you looking at your payment models to make sure that the hospitals that you're transferring patients to are not getting all the benefit where you're bearing all the risk, and try to negotiate with them, not the payers, with them, about kind of that risk share so that you can at least be made whole on that piece of the equation. And now when we think more broadly, during the COVID crisis, the Social Security and Medicare Trust Fund Board of Trustees released their annual report. And they said, and this was, went to 2018, they said, based on data up till the end of 2018, we predict Medicare will go bankrupt in 2026 and that Social Security will become exhausted by 2035. And that was before COVID and the massive increase of federal debt, which is going to accelerate Medicare bankruptcy. And as I said at the beginning of the presentation, we can expect one of two things to happen when we come out of this crisis. Maybe a reformation of the American healthcare system where we completely change how it's paid for and how it's delivered. Or maybe we keep the same model, in which case you're going to see aggressive and continuous declines in reimbursement, especially as the Medicare population grows. So especially for critical access hospitals and PPS hospitals, you can't count on your reimbursement exceeding your cost for too much longer. So let me stop and turn it back to Cassidy for questions, but let me just end by saying, your future is very much going to be dependent on how you can balance, this issue of being efficient and having enough strategic slack so that you can deal with a surge should it emerge in your community. So thank you very much for your kind attention, and thank you so much for doing this incredibly difficult and necessary job. And I really worry that America doesn't understand, and your communities don't understand how much they need you and how much they'll miss you if you go away. But if you can engage your community so that they are supportive of you, both in terms of not bypassing you for care they could get from you, but also in terms of philanthropic support, it may really help us get through this crisis. So once again, thank you so much for your leadership. Cassidy, do we have any questions?
Thank you. We are getting a couple, it looks like. So I just want to remind everyone we have a couple of minutes left. So if you would like Mr. Orlikoff to address your question, then please go ahead and type it into the chat box. Let's see, in our queue. First question, how does an urban health system management of a rural independent hospital fit into a survival strategy?
Well, in a couple of ways. First of all, you remember that what I talked about before in terms of the loss of the deductible being charged to the first site of care if you transfer a patient to the rural hospital. If you're part of the same system, the rural hospital can benefit from being part of the same system by having a more equitable distribution of capital resources from the urban facility to the rural facility to justify that loss. You're part of the same system. It's in the urban hospital's best interest for you to transfer patients to them when they realize, wow, you're taking financial hits because of this bizarre model. And if you're taking hits, that means we're taking hits. And so we're going to take some of the benefit that the urban hospital has and transfer those resources to you. So that's one immediate one. Access to capital is one. Access to clinical services is another, where you can, where they can send some of their clinical providers to have clinics or do surgeries which you can't do once a week or so. So there are a variety of benefits that come or that can come in exchange for this loss of independence.
Thank you. Let's see, I don't see anything else in the chat box. So with just a minute left, you can still ask your question, but I'm going to go through a couple of announcements real quick. So So I just want to remind everyone that CORE is opening up the application portal and accepting applications for the Vulnerable Rural Hospital Assistance Program. That will open on Monday, June the 1st, and I will link you to that portal and the program FAQs in a follow-up email, which will also include a link to this amazing presentation, the recording, and some other upcoming webinars. So back to our queue, Jamie, we did have another question. Should other states have mandatory board training like Georgia?
Oh, a couple do. New Jersey was the first one to do this several years ago, and they required a minimum of 8 hours. I think the real question is, if they do that, why are they doing it? And I think it's because organizations have failed to, create models of performance and accountability for board members. So the first thing is, I would say we need to, as individual hospitals and systems, set up mandatory continuing board education requirements. If we're going to offer you education, and if you don't get it, you're not eligible for renewal of term. Now, obviously, if you're a public district, county, or authority hospital, and that's what motivated Georgia to do this, you can't do this because you don't have control over who is put on your board. That's, at the judgment of the county commissioners or of the public if they vote for it. So in that situation, I'm afraid if we're not able to act either by social suasion, if you're a public district, county, authority hospital, or by rule, if you're a private 501c3, then it's only a matter of time before we see these requirements. And I think it'll probably, if that happens, it'll probably be too late. Remember, Georgia didn't do this until they were in the middle of a crisis of rural facilities closing. So ideally, we should do it ourselves. Practically, yes, probably more states should do this just to make certain that we're as prepared as we can be to address these challenges.
Excellent, thank you. So it is a minute after, and there are no other questions in the queue. So I will go ahead and adjourn for us. But I would like to thank everyone on the call today for making the time to attend the webinar. And sincere thanks, Mr. Orlikoff. That was a very informative and thought-provoking presentation. So thank you.
My pleasure. Thank you very much. Good luck, everybody.
Thanks, everyone. Bye-bye.
Bye.